afternoon, everyone. My name is Dr. Raquel Romero, and I'm going to be the facilitator for the ECHO session today. Thank you for joining our first session of the Community Long COVID ECHO series. And I would like to start by providing a brief overview of the comprehensive long COVID care for underserved communities innovative delivery and dissemination model project known as the Comunidad. And I will now introduce Dr. Sabat, so he is going to continue with that explanation.
Thank you, Raquel. As you know, across the country, long COVID specialty clinics have emerged to meet the needs of people experiencing lingering effects after COVID-19. Some of these offer multidisciplinary care, some of these offer multidisciplinary care, access to these services remains limited, especially for those in rural and medically underserved areas. Here in South Texas, that challenge is especially pronounced. So at UT Health San Antonio, our post-COVID-19 recovery clinic serves both San Antonio and a broad, largely rural region of South Texas with a predominantly Hispanic Latino population. This community faces significant health disparities and barriers to care, and misinformation about long COVID remains widespread. So to address these challenges, the Comunidad project, which is a 5-year initiative funded by the Agency for Healthcare Research and Quality, seeks to improve and expand long COVID care through innovative, sustainable models in our region and beyond. Comunidad has 3 aims. One is to establish a multidisciplinary long COVID clinic now underway at UT Health Kyle Seal Parkway. 2 is to collaborate with community providers on best practices for basic long COVID evaluation and management. And 3 is to share up-to-date long COVID information among the largely Hispanic Latino and rural South Texas community. So AIM 2 utilizes the ECHO telementoring modality, which is what we're on now, and is geared to primary care providers and other providers. Today's our kickoff session for the long COVID ECHO. We will have a presentation by Dr. Monica Verduzco Gutierrez on how to do a 15-minute evaluation in primary care of patients with possible long COVID, followed by a case presentation by Dr. Meves Ozel of a patient we saw this week in our residence primary care clinic. We will then discuss the case and other aspects of long COVID care with you. Following today's session, we plan to have monthly sessions covering other aspects of long COVID care. So we encourage you not only to participate, but to bring us specific cases for discussion so that we may all learn from them. Thanks again for attending our first ECHO session.
Thank you, Dr. Sabat. Now, if you are new to the ECHO platform, ECHO stands for Extension for Community Health Outcomes, and it serves as a virtual telemonitoring platform specifically designed to create a connection between communities and subject matter experts. Each session begins with the introductions, then we have a brief didactics, we have a case presentation and discussion. Now, during the case discussion, members of our community will present a real-life patient case to address their healthcare and the needs. Therefore, it's important to remember that no personal health information is allowed to express or share at any point in these sessions, and we invite you to consider and present a case in the future sessions. A few housekeeping reminders before we go to the introductions. I would like to ask you, will you please kindly, I would like to ask you, could you please put your name, add your name in the chat box, your affiliation, and your email address. This is to help us with our attendance records. If you have any issue or problem with the connection, you can always send a private message to the ECHO IT Maria for assistance. And we invite you and encourage you to be part of the discussion. You can join us by video if you feel comfortable during the discussion of this session. I'd like to move to the introductions of our routine, and I would like to start with Dr. Monica Verduzco Gutierrez. Can you please kind of unmute yourself? Thank you.
Dr. Monica Verduzco Gutierrez. I am a physical medicine and rehabilitation physician. I am the chair of rehab medicine here at UT San Antonio, and I've been taking care of patients with long COVID since the beginning of pandemic, have over 50 publications, and have been on national committees related to long COVID and spoke to Congress about long COVID and the disabilities it causes.
Thank you very much. I will also ask Dr. Sabat to now do the formal introduction of himself. You are muted, Dr. Sabat.
Hi,
Thank you.
everyone. My name's Joel Sabat. I'm a professor of medicine in the Division of General Internal Medicine here at UT San Antonio. Also direct the Center for Research to Advance Community Health. And I'm a multi-PI on this project with Dr. Radisco Gutierrez and Dr. Lisa Kilpala.
Thank you very much, Dr. De Gloria.
Hello, everyone. My name is Roy Turan. I'm a clinical psychologist with the Long COVID Clinic, where I will be providing therapy to patients that are suffering from long COVID.
Thank you very much, Dr. Osel. Case presentation.
Hi, my name is Mavis. I'm one of the PGY1s here in internal medicine, UTESCA.
Thank you. Thank you very much for joining our session today. So finally, I just would like to mention that ECHO is all learn, all teach environment. So I invite you and encourage you to participate in our conversation today. With no more from my end, I would like to pass this space to Dr. Bardusco, who is going to be a didactic presenter.
All right, let me share my presentation. All right. Thank you so much for being here today and for being engaged and wanting to know about navigating long COVID. The focus on this is going to be a short introduction, and then what can the primary care physician do in a short evaluation visit. This is just a slide with my disclosures. The main objectives today, I want you to recognize common clinical phenotypes. Sometimes you may not realize how many patients that are coming through your door with long COVID. If you think that some of maybe the most updated numbers are that 10% of people can have sequela of SARS-CoV-2, then you may not be saying long COVID or putting the diagnosis of it, but it's there. So let's see how we can recognize it. How can we apply a structured, time-efficient assessment framework for these patients with suspected long COVID? Focus history, symptom screen, and targeted physical exam. What are red flags? What needs to be done? What are key comorbid conditions that may warrant referral to specialty care? And this is the unconscious bias disclosure that is part of the Project ECHO. So just to start with the terminology, I do like to use the word long COVID. So this is, again, the syndrome that's characterized by various persistent symptoms or sequelae after someone has had COVID. You sometimes may hear long hauler. So long hauler is a COVID-19 survivor. This is a term that came up by the survivors. I do not usually use this unless a patient calls themselves that. I like to use patient first language. And then also another term that's been used is PASC, or the post-acute sequela of SARS-CoV-2 infection. That's the one that the NIH initially started using in 2021. Some other things you might hear are like PACS or PCC. So there's many things. They're all referring to what we know as long COVID. So speaking of definitions, do we have an accepted definition? RECOVER is a large NIH trial that has looked at persons who've had long COVID and also just enrolled people since around the Omicron variant, right when they got infections, to see which patients would develop long COVID. They kind of have just, saw who end up developing long COVID from these cohorts, and they did find, in their development of a definition, they came out with symptoms, what were the top symptoms that they saw in the RECOVER trial, and then there was a score that went with it. So in the initial study that came out in RECOVER, these were the model that had symptoms that defined PASC and their corresponding scores. So you can see, smell, taste, post-exertional malaise, chronic cough, brain fog, thirst, palpitations, chest pains, and you can see the list goes down. There is an update of the Recover Adult Long COVID Research Index, and so there are some of those that fell off and some of the symptoms that continued on, and there are some points related to that. So, and then the most recent analysis in 2024, again, loss of smell or taste were contributors, the main contributor to the model. That is not always very disabling for your patients. You have to think about that, but also post-exertional malaise, chronic cough, brain fog, thirst, palpitations, chest pain, fatigue, dizziness, shortness of breath, snoring, and sleep apnea. And of course, you probably see lots of patients in PCPs who show up with these things. And are they all long COVID? Probably not, but you have it on top of mind. And in the Recover Long COVID Research Index update, they come up with, from these patients that they saw 5 symptom subtypes. So you can see the subtypes from, again, a change of smell or taste, a chronic cough, a brain fog, a palpitations, and then a post-exertional soreness, dizziness, and GI symptoms. And then PEM, which is post-exertional malaise, and fatigue were prominent in all of those, at least the 2 through 5. So not through 1, but you could have a patient with fatigue, and they could follow in some of these subtypes. And then there's also a National Academy of Medicine definition. I was part of this work group that came up with the definitions. And so, they had the key elements was, the definitions, infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing, remitting, or progressive disease state that affects one or more organ systems. And then we did go into a little bit of detail about, it's a multiple 100-page document, but this is just a nice short version. And then these, ultimately we say these symptoms should be assessed and treated appropriately. And there is an ICD-10 code for it, U09.9, and this can be used even before you establish a long COVID diagnosis. So really, really encourage remembering that code and using it when you are considering long COVID, when you're doing the workup for long COVID, or when you've established long COVID. This is just, you heard a little bit about Comunidad in the introduction. So these are just some slides that are showing that. And I will start talking a little bit about, okay, a patient comes into clinic, maybe not even saying about long COVID, but I want you to think about it because, again, almost every person in the United States at this point has had COVID, not everyone, but many, many, many. And we know there can be long-term sequela, at least even defining of what is, if they're hospitalized, like 20%, if they were not 10%. And these numbers continue to be significant even with the new variant. So it's not just like the first variant or the wild type or the Omicron, but even with the most variants that we have now, people are getting long COVID. They're getting new long COVID, especially with reinfections, because now you're having people who've had COVID 5, 6, 7 times throughout the pandemic. So how are you going to diagnose long COVID? I like to say you just listen to the patient, you listen to the timeline of events. We don't have a magic lab test or biomarker at this time. Not a diagnosis of exclusion. It can also go with other diagnoses. It's not like, oh, it's only this and not that. You can have long COVID and high blood pressure, long COVID and exacerbation of diabetes, or new onset diabetes, or post-exertional malaise, or POTS, or dysautonomia, or whatever it might be, and long COVID as well. Like I said, there's not a diagnostic biomarker. I know we love blood tests, but actually listening to your patient when they tell you about their symptoms is really the biomarker that we have and that we need. And they show that diagnosis of long COVID based on like physiology or subjective reported symptoms agree nearly perfectly. So that Venn diagram is almost a circle. So if you have someone that, the tests are abnormal, they're feeling bad, or even the tests are normal, a lot of times that could still be long COVID. So what is the 15-minute evaluation? We talked about, I want patients to be, before they ever get referred to our long COVID clinic, I want to know that they've been seen and some workup has been done. And I want you to be able to consider taking care of these patients because, again, it takes months to get into the clinic, 4 or 5 months. And then, I want them to get care early. And then I also know that primary care physicians are very, very busy, are seeing patients in a more shortened time that we have. So what are the most important things that should come to top of mind when you're seeing someone who has long COVID? So I want there to be a little symptom identification and monitoring. And so these long COVID symptoms are diverse. They can affect multiple organ systems. And so a quick evaluation can help you track any ongoing or emerging symptoms that need attention or specialist referral. Definitely triage for further care. So this brief eval allows primary care physician to determine whether the patient requires more extensive testing or additional management of specialists like cardiologists, neurologists, pulmonologist, chronic condition management. So long COVID, a lot of people don't realize, actually can exacerbate or, like I said, coexist with chronic conditions such as diabetes, hypertension, mental health disorders. The ADA, every year they come up with their standards of care. In their standards of care update says that COVID can cause diabetes or also exacerbate and make diabetes be uncontrolled. And so in that case, you can, PCP knows how to manage and monitor and adjust these existing treatments as necessary to manage the overall health impact, or also consider to screen for these things. And I actually know they are actually say that after even mild COVID, that 10% of people can develop hypertension. And so that's something else that not the regular flu does or not a regular cold does. So you really need to think about that for patients who get sick afterwards. And then early detection of complications. So these regular evaluations, short evaluations, can help detect early signs of serious complications like a myocarditis, autonomic dysfunction, cognitive decline. It's not great when someone's waited 6 months to see me and then I'm diagnosing that they have POTS or that they have heart failure or something else. So, and patient education and support during these visits. A PCP can provide reassurance, answer questions, offer guidance on symptom management, and have the ability to follow up more closely with these patients. So what's important? And first thing, I like to think about, so what increases the risk of long COVID? So some of the things are getting COVID, obviously, being reinfected. So I do like to find out, like, have you had COVID? How many times have you had COVID? When did you get COVID? And was it an earlier variant? Because sometimes earlier variants, some of those patients have a certain presentation versus later variants. Were they vaccinated? Were they unvaccinated? What are the comorbidities that they had prior? So what are some of these? These are some of the risk factors for comorbidities. Females get it more than males. Middle age, having a high BMI, having a history of allergies, asthma, having a history of CKD, COPD, diabetes, heart disease, immunosuppression can be some of the risk factors. So that your patients coming in usually, may have some of these risk factors. Like I said, vaccination can be protective. We definitely know it's protective against serious COVID and, against death and being hospitalized. And it does also protect against getting long COVID, but it does not mean because you're vaccinated and you are boosted that you cannot get long COVID. There are still people who are vaccinated that can get it. And then I like to hear the timeline of symptoms because we said this was a timed diagnosis. All right. And then we're going to be looking for overt organ pathology is very, very important. So this is these are some of the main symptoms. I said that patients, when you look at the recover definition, these are the top 7 symptoms. One of them was shortness of breath. So if patient has shortness of breath, don't just be like, you're fine. They may need a chest x-ray. They may need a pulmonary function test. They may have developed new asthma. They may have restrictive lung disease. They may have, even worse type of changes that is on lung imaging, or they could have clots. And so, like I said, I don't like when patients wait 6 months later and they've had shortness of breath, then we do pulmonary function, and I have to order a pulmonary function test, and I'm a P&R doctor, so this is not part of, my practice to usually do and assess and figure out how to treat asthma. I want to treat their functional deficits and their neurologic, musculoskeletal deficits that are more related to my subspecialty. If patients are having palpitations and chest pain, again, ones that were high on that list, do they have an EKG? Just make sure, you're ruling out just some of the more serious red flag symptoms. Do they need an echo? Make sure they haven't developed some type of myocarditis, they haven't developed heart failure, and more workup based on how they're doing. If the palpitations come and go, do they need a Holter monitor before they are coming into a specialty clinic? These are just like, hear this, and then look for this overt organ pathology, because these can have red flags. And then if there is a serious neurologic impairment, then this patient may need a brain imaging or see a neurologist and have higher level neurological testing. The other thing we said, well, fatigue and PEM. So PEM is maybe something that a lot of people are not very common or don't really hear this all the time. PEM is post-exertional malaise. So what that means is sometimes someone will do an activity that they would consider would be fine and normal and they're used to doing before, but then it can cause them to crash, be very fatigued, or have an exacerbation of their symptoms. And that can happen even 2 days later. And so someone might say, I tried to clean my house and then I crashed and was in the bed for 3 days. Or I went back to work for the first time and had to do a full day of work. And I just then got my migraines came back and I got really dizzy and I had to lay down for, 3 days afterwards. And so a lot of times I just want to tell the difference between the two, because the post-exertional malaise was very high on that recover scale score. That's one of the hallmarks of long COVID, is having post-exertional malaise or post-exertional symptom exacerbation. I like to quantify fatigue and, just really like a visual analog scale, like, what's your fatigue like? 0 is none, 10 is extreme and you can't get out of bed. I have some patients that are 10. There's a DePaul symptom questionnaire, because then I want that, if you wanted to ask more detail, this is not part of the 15-minute, but just so that you have an idea of, maybe more detailed questionnaires or things that patients you might hear them say, like a dead heavy feeling after exercise, muscle weakness even after resting, mentally tired after the slightest effort. These are just things that you might hear for a patient who has PEM. One easy screening question I like to ask patients with long COVID, it is not validated, maybe it's only validated by my head, is by me. What I think is, I like to say, how many times a week do you bathe? Because you would be surprised. Like, we bathe every single day. My patients with long COVID, they might be like, I can do a seated body shower, but I only wash my hair 1 time a week. I have some patients that barely can get out of bed and have to do bed baths by their family members. So you would really be surprised that this thing that you can take for granted, patients aren't able to do every single day. Assess for dysautonomia. That's going to be patients when they have palpitations or dizziness when they get up. This is harder to do, yes, in a 15-minute evaluation, but just I want you to be thinking about dysautonomia and maybe sending them home with these things. Like, there's a questionnaire that's called the Malmo POTS score, and maybe they can take it home with them and give it to you next time they see you. And this helps differentiate POTS in healthy patients. You can give that. So doing just orthostatic vital signs doesn't always tell you the patient has POTS, because you have to do a 10-minute stand test or a tilt table test for the heart rate to go up greater than 30. And so a lot of times I'll have them try to do those tests at home and not waste your time in clinic, but you can look up something like NASA LEAM test and send it with them. So on exam, blood pressure, temperature, heart rate, saturations, those are important, the usual. You want to do, I guess I still put orthostatic blood pressure, but that doesn't mean that they don't have POTS, but it's something still that you can do there. I think a lot of times POTS is really, really missed. It's something that's very, very common after long COVID. Shortness of breath, you can, ambulate them. You can check their saturations before and after exercise. Of course, a heart-lung pulses exam, edema, basic neurologic, kind of really quick examination. And then interestingly enough, there's a lot of patients who happen to be on the hypermobile spectrum who seems to develop POTS and develop some long COVID. So if you have, sometimes I just ask patients like, are you hypermobile? Or I'll see them stand and I see that they look double jointed when they stand up. And so that also kind of clues me in. As far as labs go, basic lab work for conditions that may contribute to fatigue. You still want to rule out the regular stuff. Like I said, you don't just be like, it's long COVID and it's nothing. No, it's long COVID and maybe you have anemia. Maybe there are iron deficiencies and that have been found afterwards. There are, things, thyroid things, hormonal things. And so also if patients having cardiac symptoms, do that type of lab work. And if they have neurologic symptoms, then also look for vitamin deficiencies. So this is just from our aim 2 also is the clinical care pathway for primary care sites. So I'd like them, first to be seen by primary care, get the screening evaluation, kind of work on all we have. We don't have a magic pill for long COVID. We do symptom-based target approaches. I know you can do symptom-based target approach and start with evidence-based initial management so that only the patients that are really struggling or undiagnosed or ongoing difficulties make it to the long COVID clinic. It really is just a lot of symptom management, and we just have to treat comprehensively using interdisciplinary principles. I am not going to go into this in too much detail because these are what the rest of the echoes are going to be about. I just wanted to talk about the evaluation. And sometimes all the patients want is validation and a diagnosis. And then maybe you can see them to work about symptom management in your next evaluation in a couple weeks. But just validation of what they have goes a long way. And that's really easy to do. You don't have to I'd say, rule out the stuff that you want to order and rule out. And then, in future appointments, you can work on the symptom management. And we do have a compendium statement that came from a collaborative group that was published. It's open available and it really gives a good evaluation on what is multi-system and multidisciplinary care. So that means, multiple disciplines working together and really emphasizing integration, collaboration. And this is one of the tables from the paper, and it just talks about, the symptoms and the differential diagnosis to consider. You can look at this later, but really, and the table 3 goes into a little bit more about what are the targeted labs and diagnostics by symptoms. And then there's also been a global expert consensus that was really, really nice, nicely written as well, that gives, what systems affected and what diagnostic tests can be done. And eventually, if patients need it, then, they can maybe make it to our post-COVID rehab clinic if they have functional needs, deficits, neurologic deficits that require rehabilitation. So that's what I have.
Thank you very much, Dr. Verduzco Gutierrez. It's really, really good presentation. Thank you. I really like to say when you say patient wants validation and be heard. Thank you. Thank you very much. Is there any question, any comment from the hub team or from our learning community? You can raise your hand or you can also put something in the chat. We promise to read all the message in the chat. Okay, well, think about the question, but if there's no question right now, I would like to just go ahead and move to the case presentation for today. Dr. Zell, when you're ready, just walk us through the case.
Hi everyone, I'm going to present a case that we saw with Dr. Savat this Monday in the clinic. This is a 57-year-old female. For her general information, she has, give me a second, sorry. She has commercial insurance. She's on Community First, and she is part-time employed. She's working as a baker. Her housing status is stable. She's a divorced female with 2 children. She's getting help from her mother and her father. She had 2 COVID infections in the past in 2021 and 2023, and she had 4 vaccinations in total, in 3 in 2021 and 1 dose in 2023. She was never hospitalized for COVID infection. She has previous hospitalizations, but this was for stroke concern rather than COVID infections. She has pre-COVID comorbidities. Oh, these comorbidities aren't there, but I can tell them. Okay. She has hemiplegic migraines. She has hyperlipidemia, type 2 diabetes, class 1 obesity. She was recently diagnosed with cough variant asthma. She has allergic rhinitis, and she has hypertension. She also has paroxysmal SVT that was diagnosed by cardiology. And she also has restrictive lung disease with unknown etiology. Some of these diagnoses are coming from pre-COVID era. The ones that was diagnosed after COVID was restrictive lung disease of unknown etiology. Yeah, that is the only one which was diagnosed after the COVID. Her long COVID symptoms are significant for fatigue, brain fog, chronic cough, palpitations, and chest pain. To specify these symptoms, I can do that later. She developed new medical conditions after COVID. The one that she developed was a prolonged and consistent cough. She also develops decreased exercise tolerance and chronic fatigue. Her palpitations and chest pain, they are coming from pre-COVID time. She's fully independent on her ADLs, and she's still working as a baker in the cafe she's working, but she's also describing it's hard for her to work anymore because of her fatigue. The physical exam, when we saw her on Monday, it was quite unremarkable, actually. She was an ANO times 4 female with regular heart rates and rhythm, with bilateral breath sounds and no belly pain, no lower extremity edema. Her medications, she's been seen by pulmonology, and they had concern for cough variant asthma, so she was started on montelukast, albuterol inhaler, Symbicort, and cetirizine for nasal allergies. For her hyperlipidemia, she's using rosuvastatin and ezetimibe. For her diabetes, she has metformin. And for her paroxysmal SVT, she's using metoprolol tartrate. She also has additional medications, including amitriptyline, topiramate, pyrimidone, Depakote for her hemiplegic migraines, aspirin for her secondary prevention, and she is using esomeprazole and PRN famotidine for her GERD. If we can go back to the PDF. For her, she's a 56-year-old female with the past medical history that I mentioned. She presented to clinic with the main complaint of dyspnea on exertion, decreased exercise tolerance, and chronic cough, in addition to chest pain, palpitations, and fatigue. She states these symptoms began after her COVID-19 infection, and which has not fully resolved. Her chest pain is retrosternal, sharp, and radiating to her back. It's occurring on a daily basis, and the episodes are ranging from 5 to 10 on a scale over 10. The pain occurs both in exertion and rest. She also reports shortness of breath and dyspnea with minimal exertion, along with increased fatigue since her COVID-19 infection. And for example, when she was seen in the RBG clinic, she said to walk from the parking lot to the clinic, she had to stop more than 3 times, take a break, and sit down a little bit because her chest pain and cough was so severe. And she's saying this is really interfering with her daily life. Her like to summarize, her symptoms was kind of confusing for me because I did a deep dive into her chart. It looks like her chest pain and palpitations has been a problem since 2019. Which is not the exact time when she was diagnosed with COVID, because the first infection occurs in 2021, and she underwent a very extensive workup with cardiology, including stress tests, which were all normal. In fact, she couldn't tolerate the stress test with physical exertion. They had to do the medical one, but the findings were quite unspecific. She underwent EKG, which showed non-specific ST elevations. She has a high-resolution CT scan, which showed small fibrosis on the right lower quadrant, but the radiologist thought it was retraction fibrosis because of her osteophyte in the thoracic vertebra, so not necessarily due to a lung disease, mostly like anatomical problem. And she's also being followed by neurology because of her hemiplegic migraines. There was a couple concerns about previous strokes, but her MRI is clean, no abnormalities, and episodes without any signs of stroke. So they diagnosed her with hemiplegic migraine and treated as is. For the symptoms that started after the positive COVID-19 test are the ones with chronic cough, shortness of breath, and significant decrease in the exercise tolerance, which is very bothersome to her. Yeah, that's her.
Well, thank you, Dr. Rizal. We put together a few questions for Dr. Gutierrez or anyone else who might want to answer them. The first one I think you kind of answered already, and that is, most long COVID symptoms are nonspecific. Is long COVID then necessarily a diagnosis of exclusion? I think you said no.
No.
But on the other hand, there's a long list of labs we're supposed to obtain, and PFTs and all kinds of things. And she's had a very extensive workup. Has been to pulmonary a few times, been to cardiology a few times, been to neurology, and yet nobody has suspected long COVID other than us so far in primary care. So at what point, should long COVID have been suspected?
I would say, I like how you took how the history, and then you're like, okay, well, what symptoms were before? She's had the chest pain before. It was from 2019. That's obviously from pre-pandemic. My question was her cardiac workup just in 2019, or did she have another more recent one as well with some of these new symptoms? So even though it was okay in 2019, it's been 6 years and now things have been changed. And then really focusing in on it's the cough, the shortness of breath, and exercise intolerance that are the worst things now. And those were all things on the list, that are part of the long COVID diagnosis. And so we know that there can be inflammation in the body, there can be also microclots, and there can be other issues that are things that we don't have tests for long COVID. And I think that explains why some of the symptoms are so broad, the shortness of breath and the exercise intolerance and the fatigue. And then I think the cough is related to the asthma that she has developed, which is very common, can be common as well after long COVID. Did I answer your question?
Yeah, I think so. I think to me, what's most remarkable is her decline in functional status. know, she's in her mid 50s or late 50s, and up until the last year or two was highly functional, and now, you know, is having trouble going to work, is having trouble doing just walking a little bit, is coughing, is, you know, has some brain fog, etc. And so it's think fairly clear to us now that, you know, it's safe to call this long COVID. We've ruled out a bunch of other things. But in retrospect, I guess my question would be, you know, could we have done something earlier?
Right. I think just having it in the back of your mind when you see a patient, when you see, now just knowing that this is something that's highly prevalent, I said 10% of people who are not hospitalized for COVID. So that's almost 10% of everyone can have long COVID. So you need to almost keep it in top of mind when there's just some symptoms that won't get better, or the kind of nebulous type symptoms. But I really like that as a physiatrist, I love that you focused in on function and saw the change of function. And you have to know also or understand people's baseline functions. Because I've seen some people that they could say like, I'm running 10 miles a week, but they used to run 100 miles a week. So you'd be happy if every patient came and said they ran 10 miles a week. But if someone used to run 100 and now they run 10, that's really, really different for them.
Yeah, like you said in the presentation, just hear what the patient was telling you. This is very, very important, as you mentioned. And yeah. Is there another or is a question? Okay, so from Dr. Verdusto Gutierrez in this regards. I have a question. You mentioned during that your didactics that some people may have diabetes or may have hypertension, and then during the long COVID or after having long COVID can be either an exacerbation or maybe onset. This person have a diagnosis of diabetes. I wonder how the diabetes has been managed after being diagnosed with long COVID. I don't know if you have that in your chart, Dr. Osen.
To me, her diabetes were quite well controlled. She's just on metformin and doesn't require, like when I saw her A1C was below 7, so she didn't require any up-titrating on the medication. So I don't think her COVID increased the severity of her diabetes. And to answer Dr. Verduzco Gutierrez's question, her palpitations are coming from 2019, and she had the workup very regularly. Actually, she has a cardiac stress test in 2019, 2023, and recently 2025, which has always been negative. But I think the most important thing is previously she was able to tolerate exertional stress tests, but in 2025 she couldn't tolerate it, so they had to do the medication-induced stress test.
Right.
The only thing that would tell us she has an underlying cardiac disease is the high-resolution CT scan showed cardiac calcifications. Of course, we don't know the extent because she never had a left heart cath. But at the same time, the stress test is normal, TT is normal with a normal ejection fraction, ECG is normal. So I don't know which disease is triggered or got worsened with COVID, but the life quality looks like it got worsened. Yeah. Does that answer your question, Dr. Amora?
I think that did. And then I'm just going to put a little extra thoughts into it as well about, the things that are worse and things that, it seems like, yes, you're right, amazing. She's had all these workups, and then the last year she couldn't do an exercise stress test. She had to do a medicine-induced stress test, which tells us about her level of function as well. And she's having, cough and shortness of breath too. And has had seen in pulmonary and everything. I almost also wonder, sometimes some patients need CPET testing as well. I don't know if that had been considered or if that had been done on her, because I think that CPET might be a consideration. It may tell us a little bit more of like, is this a pulmonary thing? Is this a a cardiac limitation? Is she just kind of debilitated? And then the other thing that I'd like to, as I think and I hear her story about like what else can be done or what else haven't we looked at, is there is a lot of oh my gosh, what's it called? That patients will have a lot of issues with how, because you said, well, she has restrictive lung disease. So also there's going to be a lot of patients have issues with when they take deep breaths that their diaphragm isn't, extending the right way. And so they have a paradoxical breathing pattern. So if you're always with a paradoxical breathing pattern and you're always, and you have some restriction in your lung as well, you're going to be feeling short of breath all the time. So even having the patient work on breath work, having the patient maybe see a physical therapist to work on their paradoxical breathing pattern can help with their shortness of breath a lot. Because if they're, not breathing the right way and trying to do their activities, that's not going to be really very good for them. So. And then really, I always feel, a couple other things that I was thinking when you were talking that, long COVID, I feel like it's an immune-mediated endotheliitis. So that means it's going to affect any kind of system. And if there is endotheliitis, then that can just also cause exercise intolerance because you're not getting as good blood flow to your muscles and you're not getting good blood exchange in your lungs too. And then the other thing with someone who has diabetes, and I looked at her med list that she is on metformin, and something that I don't know if a lot of people realize that actually they had done studies when patients had acute COVID, and once you're on metformin when they have acute COVID, it actually decreases people's risk of having long COVID by 40%. And so it's actually something that we should probably be considering treating our patients with antivirals if they're at risk, and also with metformin. And then there is some, thoughts and considerations that they'd like to maybe take metformin because of how it works and the anti-inflammatory effects and such, to maybe even treat some patients with long COVID. So I always feel like if if they already need it, then it's not a bad idea to have them on it.
Well, thank you very much. There was a very good information, very good discussion. Just to honor everyone's time, we have just a couple of more minutes. Dr. Saba, you have a summary of the recommendations to as a
Yeah,
discussion?
thank you for the presentation and discussion. From a primary care perspective, I think this is challenging in a number of ways. One is, the complexity of the patients and the amount of time that they may require and all that. But even more so, there is we live in a society where there's denial. There's denial of COVID-19. There's denial of long COVID, even among some health professionals. And then there's misinformation. And so all of those factors weigh into, if and when the patient presents and how we think about their constellation of symptoms. I think some take-homes, though, are just some simple things. One is you see a patient with symptoms like this, you can ask, did they have an infection? In this case, COVID-19, but it could have been some other viral infection. It could have been, some non-viral infection. And if so, did their health status get worse after the infection? Think if you ask that, then you are at least kind of, your mindset is thinking, okay, this could be long COVID or some other post-infectious chronic condition. And then, if you can recognize the pattern, Dr. Gutierrez talked about 5 symptom subtypes. If you can kind of classify the patient in your mind, well, I think this person probably fits this 3rd subtype. That's useful. I think as she said, there's many things we can do ourselves in primary care, but we do have resources. You can refer patients to the long COVID clinic. We also have Recover clinical trials going on in San Antonio. And so that's a resource for all of you providers. And last but not least, as you said, a lot of patients are looking for validation of their symptoms and their suffering. And so that's the very first thing we can do.
Thank you. Thank you very much. Thank you for this great information. It was a wonderful learning opportunity. Dr. Sabat, thank you for the recommendation. And Dr. Monica Verduzco Gutierrez for this wonderful presentation, didactics, and Dr. Zell for the case. Thank you all to be with us today. This is going to be a monthly sessions. We hope you mark your calendar for December 4th, and it's going to be at the same time. And also, please check the link for the continuing education credits, and I hope to see you next time. Thank you very much, and you have a wonderful day.